then I'll. Welcome everyone to our H5N1 webinar today, brought to you by our Region 7 Regional Emerging Special Pathogen Treatment Center here at Nebraska Medicine UNMC in Omaha, Nebraska, as well as partnership with the Region 7 Disaster Health Response team here, also based at UNMC Nebraska Med. So I'm Shelley Sweethelm, a nurse by background and a leader here at the university and involved in many of our grants. And I currently serve as the Associate Director for the Global Center for Health Security. So I'm going to facilitate the conversation today and the question and answers at the end. I grew up on a dairy farm. I've been an egg girl my whole life. So this is a topic that's definitely near and dear to me for sure. With that said, though, our focus today is going to be on healthcare and then some of the public health considerations. So if you have questions about the animal health side of things, we're going to briefly touch on current state, but that won't be the focus of our time together today, and instead really want to focus in on any of your public health, healthcare focused questions that you might have about this pathogen. So I want to introduce our speaker today. Our speaker is Dr. Angela Hewlett. She's a professor of internal medicine and infectious disease here at the University of Nebraska Medical Center and at the University of Nebraska College of Public Health. She's also the George W. Orr and Linda Orr Chair in Health Security here on campus. She serves as our medical director of the Nebraska Biocontainment Unit and the associate medical director of the National Quarantine Unit, where she actively participated in care of several patients back in the 2014-15 timeframe who had Ebola virus disease and were repatriated to the United States, as well as many of our first patients in the United States with COVID-19. She's provided subject matter expertise through the National Emerging Special Pathogen Training and Education Center, otherwise known as NETAC, and the HPAI CDC Outbreak Response Training Program, and multiple other national and international biopreparedness advisory groups and venues. She served as the director of the COVID-19 infectious disease team here at UNMC Nebraska Medicine as we were navigating through that, and also served as an expert and support to the U.S. Olympic team and Little League International as we navigated COVID. She's one of our scholars here in the Global Center for Health Security and the National Strategic Research Institute as well. And she's authored a lot of publications and book chapters on the topic of infectious disease and special pathogens. So we want to welcome her today. Next slide. We have no disclosures to speak or tell you about. And then finally, the objectives for today are that Dr. Hewlett's going to run through the characteristics and origins of high-path avian influenza, otherwise known as H5N1. She's going to talk a little bit about the modes of transmission of the high-path avian influenza, including animal to human transmission that could contribute to the spread of disease, and why we're worried and could use some definite guidance about all of this as we navigate the next few months. She's going to discuss the current guidance for healthcare facilities and clinicians in reference to the adage from CDC of identify, isolate, and inform. And she's going to also help us understand where to access available resources, guidelines, and training materials to effectively manage and respond to high-path avian influenza outbreaks. So we have the Q&A there at the bottom of your screen. So feel free to put your questions in that box. And then if by chance one of you sees a question there that you're really interested in as well, go ahead and just click the like button there, or whatever button it is that kind of brings it to the top of the list, and we'll get to questions and answers at the end of our time together today. So with that, I want to turn it over to Dr. Angela Hewlett.
All right, thank you very much, Shelley, and thank you for your time today on this very, very hot topic. I will say, I know we've been seeing a lot of information in the media as far as the initial case, a human case that's been identified, as well as the outbreak in dairy cattle. And so some of the slides here are meant to kind of clarify some of those issues, as well as just think about our response and how we would potentially respond at our healthcare facilities should we start to see more widespread human cases of disease. Next slide. So very, very briefly, just a brief refresher for us on influenza, which is an RNA virus. It's in the orthomyxovirus family. There are actually 4 types of influenza. I'm not sure if anybody's heard of C or D as much, but A and B are ones that we hear about every year that cause our seasonal flu outbreaks. Influenza does affect both birds and mammals, obviously including humans. Next slide. And when I talk about H5N1 today, just again, a very brief refresher on what those mean. So the hemagglutinin protein is the H protein or HA protein, and that actually allows the influenza virus to bind to our cells and our respiratory tract in order to initiate infection. And the neuraminidase protein, or NA or N, helps release that new virus from the cells so that that virus can continue replication and cause disease. There are lots of different combinations of both H and N proteins, but again, as an example, thinking about H5N1, that's the HA5 protein and NA1 protein, and there are actually 9 known subtypes of influenza A H5 viruses. So H5N1 is not the only subtype of the H5 viruses, but it's the one that we're going to refer to today. Next slide. So just to kind of go back a little bit and talk about influenza A in birds, which is where we hear about this the most, as far as types of, highly pathogenic avian influenza. There is a low pathogenic avian influenza, though, or HPAI, and this typically causes either asymptomatic or very mild disease in birds. However, it can mutate into highly pathogenic avian influenza. And then that actually, the HPAI, is the one that we'll talk about today. And that is severe disease, typically has a high mortality in birds, and it can affect birds differently. And so some of the H5, H7 viruses have close to 100% mortality in say chickens, but ducks tend to be asymptomatic. So, there's a wide variability in how birds are potentially affected. However, these viruses spread very rapidly through poultry flocks, and over 90 million birds in 48 US states have been affected since January of 2022. So just think about that as far as the numbers go. And there's actually this link down there at the bottom at the CDC has a ticker and of the number of birds that have been infected since that time. Next slide. So along with birds, influenza A can also affect mammals. And, 26 countries have reported more than 48 mammal species infected with influenza A or H5N1. Potential sources of infection, close contact with infected birds is really what is thought to be the primary mechanism. But also mammal to mammal transmission, there have been sort of multiple reports of that potential. The most recently, minks actually transmitting to one another. And so that is also a potential mode of transmission, as well as contaminated equipment utilized on a variety of different farms or other places. And you can kind of see by the pyramids there, which I found really interesting. Between 2003 and 2019, you can see the number of species that H5N1 was reported in were relatively small, whereas from 2020 to 2023, a lot more species have been involved, including some really interesting ones. But, either way, it does look like that this virus is actually affecting more a variety of different mammals and different species compared with times in recent past. Next slide. In humans, influenza A has been actually reported, multiple human cases have been reported in 23 different countries, starting in 1997. So 97 was the first reported human case. There are about 900 cases total, and it can cause severe pneumonia and death with a mortality rate of around 50%. And so this is why we're obviously concerned about this. If you think about this compared to, say, something like the SARS-CoV-2, where the mortality rate was, generally less than 1% for the most part, this is a very significant threat. There are other viruses that have a similar mortality rate. I would say MERS-CoV is another one that we have been concerned about because of a mortality rate of around 35%. So 50% is obviously very significant and something we need to pay attention to. Spillover in humans, so virus transmitting from animal to humans, has been associated with very close contact with infected animals and particularly poultry in the past. Birds tend to shed the virus in their saliva and their mucus and their feces, and then humans are exposed either through their respiratory tract or through their mucous membranes, very similar to how we would be exposed to another person with influenza in human-to-human transmission. And so what's the risk of this to humans? And, right now there have been, again, a myriad of sporadic infections essentially reported since 1997, but what we have not seen is sustained human-to-human transmission yet. And I put yet on this slide on purpose. If this happens, then there definitely is pandemic potential here. And that's the reason we need to really pay close attention to this. There is a fair amount of historic precedent. One example is the 1918 influenza or Spanish flu was actually thought to have avian origins. And so, this is something that we really do need to, to continue to monitor very closely, because although we haven't seen that sustained human-human transmission yet, it is a possibility that could occur. Next slide. And just to illustrate the concern, when I mentioned the 50% mortality, this is a table from World Health Organization that shows that case fatality rate of around 52%. So again, very, very significant. There are a variety of different countries you can see on the left there that have reported cases since 1997. Next slide. So influenza A in cattle. And Shelley did mention, that we're not going to get into this, in depth. There's a good reason behind that. I think we're really talking about human cases right now, but and I will say I am no expert in cattle, and I unlike Shelley, do not live on a dairy farm or have that experience, and so I again we'll comment some on this, but definitely there's a lot going on in this arena currently. So I had to update this slide, and this is actually very reminiscent of what happened in COVID when we were giving presentations, during kind of the very rapidly evolving issues during the COVID-19 pandemic. In that I had to update this slide this morning out of the most recent case a couple of days ago that was reported in Colorado. And so currently there are 9 U.S. states that have influenza A outbreaks in dairy cattle. There has been spread between different herds into nearby poultry flocks, as well as into barn cats, actually, that were associated with those infected farms. This is the new map that I just put on this morning that does list Colorado as a state that has seen cases as well. Next slide. So as far as human cases of avian influenza in the United States, the most recent case is actually not our first. There was a person that tested positive in 2022 in Colorado. That individual had direct exposure, occupational exposure to infected poultry, but really had relatively mild symptoms. Fatigue was the major symptom, and that individual was treated with oseltamivir and recovered. So far in the current outbreak, 1 human case has been reported, resulting from that dairy cattle exposure. And this was also an individual that had occupational exposure to dairy cattle. This individual actually presented with conjunctivitis as essentially their only notable symptom. And they were treated with oseltamivir, they recovered. There were multiple contacts of this individual and as well as household members that also received oseltamivir for prophylaxis, for post-exposure prophylaxis. But there were no secondary cases identified as of yet. Thus far, only 1 human case has been reported as a result of the outbreak in dairy cattle. Next slide. So what are the various groups doing about this as far as the investigation goes? You can see the groups listed there: CDC, USDA, FDA, lots of other agencies all working together. I attended a call last week where the various agencies gave their reports. And this was encouraging to see these different agencies coming together during this outbreak. And so there are teams from all of these agencies that are on the ground investigating the outbreak at the dairy farms. There's routine testing of dairy farm workers as well to kind of understand what are those occupational risk factors for exposure and potentially for disease. There's routine testing of cows and milk supply, and I'll get into that a little bit more in a second. Surveillance of other species as well on the farm, both wild animals as well as those that are located on the farm. And then there's viral sequencing going on of this virus, and this was something that was kind of on the top of our minds as far as what type of changes we were potentially seeing with this virus when after it was identified in both the individual human as well as the cattle. And thus far, no major genetic changes have been seen, is my understanding. No markers of antiviral resistance either. And the virus is actually closely related to both of the candidate vaccines that we have. And so this is encouraging thus far. But again, this is not something that couldn't change in the future as well. The CDC is also notably monitoring influenza-like illness, diagnoses. And so looking at diagnosis codes and also looking at test utilization for a variety of different tests that are run on individuals that present with symptoms. And so looking at, is there an uptick in that area? And thus far, they have not seen an uptick in any of that, which is also encouraging. Next slide. So what are we doing as far as guidance and outreach during and following that investigation? And so this was something that was also reported on in the webinar that I attended recently, and a lot of development of guidance in these areas. You can see some of the links that I've listed here, lots of different guidance documents, messaging to farm owners, agricultural groups, a variety of different groups, and really requesting them to really partner with public health in order to ensure the safety of their workers, but also of the herds as well. There are some considerations for veterinarians that are published. There is actually talk of thinking about the utility of wastewater surveillance like we have done during the COVID-19 pandemic, maybe seeing if there's a signal in that area. I will say that is fraught a bit, just in the fact that birds obviously are using that water, potential runoff from the cattle farms and such. And so whether that's actually able to predict human disease hasn't really been determined yet, but that is something that people are thinking about. And then you probably heard about the USDA issuing the federal order, which was issued last week, effective today, where there is mandatory testing now for any movement of dairy cattle between states. And then laboratories and state veterinarians are now required to report positive tests to the USDA and APHIS. And there are, again, lots of guidance documents available online that detail these recommendations. Next slide. So what is in the Strategic National Stockpile? This is a question that I think on every webinar that I've attended thus far, we get a lot of questions on this. So antiviral medication, yes, there is antiviral medication stockpiled. It's mostly oseltamivir or Tamiflu. There are others as well, and you can see some of the others that are listed on the slide there. But as I mentioned earlier, preliminary analysis, genetic analysis, did not find changes that would make these viruses thus far, at least, resistant to current FDA-approved antiviral medication. And so that is very encouraging. That is something, though, that we need to definitely watch for. There are candidate vaccine viruses available in the Strategic National Stockpile. Now, one thing to clarify with that is we don't have a giant large vaccine stockpile, pre-made vaccine stockpile. And the reason behind that is because you really can't stock those in any, significant quantities without them expiring and not being useful. And so what they do have in the SNS are the antigens that are available that could be ramped up quickly into production to produce vaccines. Just notably, the seasonal flu vaccines that we all receive every year do not provide any protection really against these viruses. And so this would be something that we would need a new vaccine available, not unlike what happened in 2009, for those of you that were around during the H1N1 pandemic. How we had to have an additional vaccine in addition to our seasonal flu vaccine that was developed. And so this is, there are antigens in the stockpile, but not pre-made vaccines as of yet. As far as personal protective equipment goes, the folks that run the Strategic National Stockpile have mentioned that they don't have any notable current supply shortages, which is important. I'm thinking about the need to deploy potentially personal protective equipment should we see more cases. And this is something I know we all have recent experience with COVID-19 and needing to make sure that we have that personal protective equipment to protect our healthcare workers. Next slide. So how safe is the milk supply? This is the really hot topic, I would say, as far as coverage in the media over the last couple of weeks. So yes, there has been viral genetic material found in retail milk, in raw milk as well as pasteurized milk. But remember, genetic material does not mean live virus. There's a distinct difference. Genetic material is having a positive PCR, but not necessarily translating into actually being able to culture the virus. And so analysis as far as viral culture is currently happening right now. And you probably have seen reports that very recently, I believe it was on Friday, there was actually some preliminary testing conducted on pasteurized milk, and it does look like that they are not able to currently culture this virus out of the pasteurized milk, which is very encouraging. Previous looks at influenza as well as a variety of different other viruses have been conducted on pasteurized dairy products and with good results, and the fact that they weren't able to actually culture live virus. So, if you have viral bits that are being detected via PCR, that definitely does not translate into infectious risk of that material. Now, that being said, there have not been a whole lot of comments on raw milk, and that is something that is definitely a hot topic, and that the vast majority of milk products sold in stores, about 99%, actually does undergo the pasteurization process. But there is, and as you know, I'm sure, some individuals who prefer raw milk. There's a market for raw milk out there. As an infectious diseases specialist, I'll be really honest, I don't understand that, not necessarily for influenza, but for a variety of different other illnesses that occur with non-pasteurized dairy products. But that is something that is out there, and we have not heard a whole lot of comments on that as of yet. There is nationwide surveillance being conducted, looking at a variety of different stages of milk formation, whether that's directly at the farm versus, as I mentioned, after the pasteurization process. But what this does show us is that the fact that a lot of this virus, at least pieces of the virus, have been found in the milk supply, does indicate that this is probably more widespread, and there are probably more herds that are infected. This is probably more geographically widespread than initially thought. Just something to consider. Next slide. So now we're going to kind of focus on guidance for healthcare facilities and clinicians, thinking about our response here as leaders in healthcare facilities, as well as working closely with public health to ensure that we're doing the right thing for not only our healthcare workers, our patients, but as well as the general public. Next slide. So, all of us have heard identify, isolate, and form a whole lot. Avian influenza can present just like any other viral illness. There are not really any notable distinguishing features with this, at least based on previous cases that have been reported. It can present with very mild illness, so maybe cough, sore throat, conjunctivitis, as I noted with that one individual human case. Fever, runny nose, fatigue, the usual stuff we think about when we think about flu. Do note that gastrointestinal manifestations are up there. There are some people who have notable, nausea, vomiting, diarrhea, potentially from influenza as well. So just something to consider as far as that goes. And then more severe disease would be something like shortness of breath, altered mental status, seizures, lots of other kind of more severe manifestations as well. But there's no distinguishing features as of yet of this virus, that we could really tag onto. So I think the key steps are really suspicion of a viral syndrome, and whether that, there's still regular influenza A and B circulating around. Obviously, COVID is still out there, other viruses around, but thinking about, is an individual, are they presenting with something that could be consistent with a viral syndrome? And then also thinking about taking that next step to ask about epidemiologic risk. Next slide. So this is a super busy slide, and I put it on here on purpose. And the reason behind that is because, this is currently what's available as far as potential risk factors for individuals for H5N1. And so, this is straight out of the HAN, the Health Alert Network update that just came out, also as well as the CDC website. And you can kind of see individuals that have a respiratory infection, which is what I just talked about, as well as all these other things. And so people who have particularly an occupational risk associated with animals, whether those are, sick or dead animals, and that could be everything from slaughtering or consuming undercooked or uncooked food, including raw milk is listed up there. Direct contact with contaminated surfaces as well is also listed as a potential risk factor. People that have had prolonged exposure to, birds or other animals in a confined space, and then any exposure to an individual that is either confirmed, probable, or a symptomatic human case, which again, thus far, we only have one that we at least know about. And so, this is a lot of stuff, right? And this is going to be very difficult right now to be asking, upfront. And so next slide. So I think what I elected to do is go ahead and kind of let you know our approach here and how we're thinking about this. We've had a variety of meetings lately involving infection control as well as other hospital leaders, and just thinking about how are we going to best screen for this scenario. Because, Nebraska, like lots of, pretty much all the states actually in this region, there are a lot of dairy cattle here. There's definitely a potential for more infected herds as well as potential transmission to humans. And so our approach has been, and I caveat, I say this, not one size fits all by any means, but just letting you know how we're approaching this. So what we do up front, and this is not new to H5N1, but we assess fever, cough, or rash on every single patient that comes into our facility, whether that's in the emergency department or in clinics. And the reason behind that is because that can really, hopefully delineate at least, relatively well individuals that present a potential risk of infection in our waiting rooms, in our healthcare facilities. And so whether that's measles or COVID or anything else, we want to identify those individuals and then appropriately manage them, as well as hopefully decrease the risk of transmission. And so we ask that of everyone that walks in the door. If someone answers yes to that, then a mask is provided, and then the individual is triaged based on their symptoms. Obviously, if they're severely ill, they are taken back to a private room for assessment. If it's appears to be a mild illness, they may sit somewhere in the waiting room away from others for a period of time. But we really try to get those individuals assessed as soon as possible, and again, have some source control on that individual with a mask. And so then after that, what happens is a further assessment by a provider. And we also have, we ask travel as well of every patient that comes in, which is not necessarily relevant for this scenario, but is something that we do ask. And that is all through our electronic medical record system as well. So further assessment. So when the individual gets in a room, the provider will ask them, and this is our question that we've chosen to ask: do you or a household member have direct contact with cows, poultry, or wild birds? So this is very different than the myriad of information that you saw on the previous slide. But I think, as far as an initial screening question, this is what we have chosen to ask at our facility. And then, obviously this is a moving target. And so we really need to think about, we can consider adding additional questions if circumstances or any risk factors change. If this is being linked to raw milk consumption in humans, then yes, we need to add that as a potential question that we ask. If we see a lot of sustained transmission, local cases, things like that, then we may very well consider updating these questions. But for now, this is what we are asking. Next slide. And so what do we do? I mentioned putting a mask on the patient to provide some source control. We isolate that patient and utilize appropriate PPE, which for this illness is standard contact and airborne precautions, not unlike COVID-19. So we all have a lot of experience with this over the last few years. So gown, N95 respirator, eye protection, and gloves, and obviously meticulous hand hygiene plays into that as well. Just like COVID-19, the recommendations for this illness are preference for an airborne infection isolation room, if possible, so negative pressure room. But if one of those is not available, then you should put the patient in a private room with the door closed, and then the patient should continue to wear a mask for source control if you do not have that airborne isolation room available. There are some environmental infection control considerations, but actually for this illness thus far, it is recommended that standard cleaning and disinfection is appropriate, as well as standard medical waste management. And so this is not something that requires special handling of medical waste as of yet. Next slide. So what do we need to do? The notification process, really important at your facility. And so the first group that we notify is our Department of Infection Control, which is appropriate. They need to be involved from the very beginning up front. I imagine probably are the authors of the local guidance as well. And so, that is something that, if you do see a patient that is a person under investigation potentially for H5N1, then infection control should be the first people to be notified. And then notifying appropriate medical teams who will care for the patient, obviously to ensure that they're wearing appropriate PPE, and have some supervision of this process as well is important. And then notifying local, local officials, whether those are hospital or departmental leaders. That's something that we really learned, is a very important step, so that the healthcare facility can be aware of what's going on. And then notifying, obviously, the state and local health departments to discuss the scenario and talking about the potential risk factors, as well as arranging for testing and making sure that that is done appropriately. Next slide. And so as far as testing goes, this also has some information from our facility. The testing for this illness is currently available at the CDC as well as the public health laboratories. There are no currently available commercial lab assays, but this may change. And so right now, you can't send these testing off to all the different commercial labs, but that is something that definitely could be added, very reminiscent of what occurred during the COVID pandemic. And so I advise, consulting your local lab for guidance on the testing algorithm. Our usual antigen test and some of the PCR tests actually will not differentiate subtypes. And so they won't tell you whether this is influenza A H5N1 versus influenza A H1N1, or some of the other kind of seasonal influenza viruses that are circulating around. And so, for instance, here at our facility, and we really had to contact our lab and kind of sort this out. We have what's called a respiratory pathogen panel, which has a myriad of different viruses on it, as well as influenza A. And if someone does tag positive for influenza A, there are 4 different results. And so it's either no subtype, or you can see H1 or H3 are listed. And so avian influenza would come back as no subtype. And so that should trigger a further evaluation. Our lab will monitor for this. And if we do start testing people with this and we see that we're seeing no subtype as a delineation on the respiratory pathogen panel, then that's when that needs to trigger further testing. Because particularly, the concern is that, when this individual presented with conjunctivitis, they obviously had a very notable epidemiologic history. But that being said, there may be, a very low level illness or, relatively mild symptoms when individuals present. And it's essentially indistinguishable from other clinical syndromes that cause very similar symptoms. So just something to remember. And you may just want to go ahead and proactively contact your lab to see what this would look like, on your currently available testing. Next slide. And so this is pulled straight off of the Health Alert Network, as well as the recommendations from the CDC. And the reason I bring this up, and the other reason to really contact your lab and discuss this with them in depth, is that you want to make sure that you collect the appropriate specimens. And this is something that, you definitely don't want to collect a specimen that they won't be able to process in way, shape, or form, because every time we collect a specimen, we're obviously involving the patient and potential for transmission as well. And so what the current recommendations are for specimen collection are collecting either a nasopharyngeal swab, which I know we're all very familiar with from COVID, a nasal aspirate or wash, or 2 swabs combined into 1 viral transport media. So something like a nasal swab and an NP swab combined, or an NP swab combined with an oropharyngeal swab as well. So these are kind of the options that are recommended. However, a single nasal or oropharyngeal swab is also acceptable. And again, I know we're all very familiar with that type of specimen collection from COVID. If someone does come in with severe respiratory illness, a lower respiratory tract specimen is also appropriate. So, an endotracheal aspirate or a bronchoalveolar lavage can also be collected and sent as well. And then as far as the transport goes, that's another thing to make sure that you're discussing this and that you have all of this well delineated as far as how we're going to transport these specimens, what type of media they need to be in, just to ensure that those specimens can be processed. One notable thing, since we've seen 1 human case that has involved conjunctivitis, is that if you do have somebody who comes in with conjunctivitis, it actually is appropriate to collect a conjunctival swab for testing. And I will say, and this is with or without respiratory symptoms. So if you have someone that comes in with conjunctivitis, they have appropriate epidemiologic risk, it is reasonable to actually collect a conjunctival swab. And the reason I say this is that the individual who developed conjunctivitis and in conjunction with H5N1 actually had a fair amount of virus actually in the conjunctiva. And so this is something that, again, is a manifestation that so far has been reported and that we need to respond to by making sure that we're testing appropriately. Next slide. And lastly, treatment. So if you do have a high suspicion for influenza A H5N1, it's recommended that you initiate empiric antiviral treatment. So don't wait for the lab results to come back. If you have someone who has an appropriate symptom presentation as well as a appropriate epidemiologic risk, then go ahead and initiate treatment. And again, these individuals may very well have seasonal influenza as well, but it is important, especially if they have that epidemiologic risk, to make sure that we're treating these patients appropriately. You also should treat regardless of duration of illness. All of the antivirals are more active and more efficacious when started early in the disease course. But it is recommended that even if you do have an individual who is multiple days into their symptom onset, it's still appropriate to go ahead and treat that individual with antiviral medication. And the antiviral medication that is recommended for H5N1 is oseltamivir, and that is the one that has been around the longest, that we have the most information about, and that's the reason for that recommendation. And the dose is 75 milligrams twice a day for 5 days. That's the appropriate kind of influenza dose that a lot of us are familiar with. However, kind of like with seasonal influenza, if you do have an individual who is severely ill or has a prolonged illness, you can actually consider lengthening that duration of therapy as well. Prophylaxis, and this is an important point because it's something that I was not aware of, but the prophylactic dose for close contact. So if you are taking care of a patient and you need to provide prophylaxis for their household members or other close contacts, is actually the same as the treatment dose. So 75 milligrams twice daily, which is different than and very distinct from the prophylaxis dose that we typically utilize when we're dealing with seasonal influenza. So that's something that is a little bit different about H5N1. And there are guidelines for this. I list the CDC link there, but this is also something that we would need to continue to evaluate as time goes on. But that is the current recommendation as far as management of these individuals. And then obviously good supportive care, like we would do for any individual with a viral illness, including other types of influenza. Next slide. And this is the final slide, and it's an important one because I think, making sure that we have access to resources available. I used a whole lot of resources when I was making this talk. I learned a lot actually over creating these slides. There is a lot of information out there, and you can see some of the various links here, for current information on this outbreak, as well as kind of historical context and other things. There is also general information, and the places that I tend to go when I'm looking for really up-to-date information on an evolving outbreak are sites like the Program for Monitoring Emerging Diseases, or ProMed. This is a website that has a really nice kind of reporting of illnesses and really up-to-date information. And that's actually how I found out about the first cases of COVID-19 as well. In the end of December of 2019, was actually looking at the ProMed site and seeing some of the reports out of China of the respiratory disease going on there. And so, the transmission is also an excellent resource. This is a weekly newsletter, email newsletter that actually is published by the Global Center for Health Security here at UNMC. I use this a whole lot in this presentation and definitely rely on it because it is a really nice resource that really kind of pulls everything together. It's a weekly, as I said, weekly email. And then, CDC Health Alert Network, obviously signing up for updates through that. NETEC, has an excellent website with lots of different resources on a variety of different topics, including H5N1. We provide consultation resources as well to assess readiness at different facilities. And so, our website has a lot of information about that. And so if you are interested in having a consultation for your facility, or you have questions or please, contact us for that. And then as far as Region 7 goes, we are the RESPECT here in Region 7, and we, feel free to request trainings from our team. There's an email address listed up there for Jackson Gruber, who's on this call, who also really can provide some excellent information and resources, should you require it. And so I think, having up-to-date access to these things is important, and particularly for something like this that is rapidly evolving. And I keep referencing COVID-19, but this is somewhat reminiscent of that, at least at least very early on when there was a lot of information that was being sort of modified and changed as the days go on. And so now, that not saying that this will result in anything remotely like COVID-19. This may be something that we see a few sporadic cases like what has occurred thus far and don't see sustained human-human transmission. And I know we all hope for that scenario, but we obviously need to be prepared regardless of what happens, and particularly, again, to protect our healthcare facilities as well as the general public. So I'll stop there and we can start answering some questions. Thank you very much for your attention.
Yeah, that was great, Dr. Hewlett. Jam-packed, of course. While we're on this slide, I just want to tell folks there was a question in the chat about EMS guidance. And just to let you know, NETEC will have some EMS guidance that'll be out by Friday this week. So stay tuned, go to netec.org. That's also a good location for you if you're from outside of Region 7, which is Iowa, Kansas, Missouri, Nebraska. There are 12 other regional treatment centers across the U.S., and there's an interactive map that you can click and find out who your go-to person is in your own region across the country to be able to ask any other additional clarifying questions as well. So, and NETEC also has an ask a question opportunity on the website. So let's unshare this screen and we're going to go to some questions in the chat. And Dr. Hewlett, we're going to have a little bit of a combo here of some healthcare questions and some ag questions, but I think on the ag side, I can tell them where to go to get information. So with that said, our first question is, there are many anecdotal reports of sick people on farms where there are infected cattle, and that is indeed true. That's been out in the public media. Given that 2.3.4.4b appears to be much less pathogenic, first of all, I'd like you to validate whether that's true, than historic strains, most people recover. Although we've only had one example of that so far that's been documented with confirmed testing. Has there been any antibody testing of humans on affected dairy farms? And is there any indication that this clade is not causing severe disease, even if infections may have occurred? That's a whole lot of stuff in there. So I'll let you respond first.
All right, yeah, I'll do my best with this. I agree. This is definitely a multi-part question. So first of all, yeah, we've only had one human case thus far reported for at least in this year, and so I think it's very early to judge that this will not necessarily cause more severe disease. There is a chance that this could be a lower pathogenic kind of scenario where you may see individuals with relatively mild disease. We're all sort of hopeful for that, right? But that is something that we with one case can't really comment a whole lot on. In the past, and I will say this is true of a variety of different epidemics, pandemics, et cetera, that obviously the people that are the sickest and that are, kind of tagged onto very quickly are the ones that typically present for medical care. And so it may be that this 50% mortality that we've seen with this illness in other parts of the world, it may be that there is some mild illness going on, but we're just not tagging onto those individuals. And so, I know that happened with H1N1 in 2009, where, there were a lot of people with very severe disease and death and dying actually in Mexico City at the time. And it was very, very concerning that this was a disease with a high mortality rate, when in actuality, that was sort of the tip of the iceberg. And there were many, many people who had relatively mild disease who just weren't presenting for medical care. So there's definitely a possibility that is going on. As I understand it, there is testing going on of individuals who do have occupational exposures, particularly to those infected, known to be infected herds, and so they are testing humans and as well as other surrounding animals, both farm animals as well as wild animals that are found in the area. And so there is a fair amount of surveillance going on with regard to that, and that's an important part of trying to determine how widespread is this actually. So I think that's, yeah, there's again, a lot of parts to that question, but this is an evolution, and I think we'll learn a whole lot more. Hopefully we won't see, sustained human to human transmission here. Hopefully we won't see a huge number of cases, but there is a chance that this is the tip of the iceberg, and there are a number of humans that have been infected, maybe with very mild disease.
Thank you. Our next question is, as we proceed into county fair and state fair livestock shows, what are the recommendations for testing and containment? I think what I would say as the ag girl who has grandkids in 4-H and have been around this my whole life is I would say stay tuned. Lots of really significant agencies are integrated at this time, like Dr. Hewlett mentioned early on, and extension agents are very tied into their USDA, dairy associations at the state level, all of the above. So, and now we've got the new federal law that went into place today. If you're going to a fair across state lines, that certainly now requires you to have some testing within the 7 days prior. So for dairy cattle, nothing yet for beef, although I do believe there'll be some proactive looking at what's going on in beef as well. So I would just say stay tuned, and your local extension agents will likely have some things, and good hand hygiene. Next question is, how did they decide to test the person? Any feedback from that on the one that had just conjunctivitis?
Yeah, I mean, this individual was actually again, an occupational exposure to a known infected herd. That was the reason why they decided to test this person that just had conjunctivitis. But I would say that, kind of like, I mentioned in the slides, if you have an individual that has notable exposure, a lot of exposure to to dairy cattle or birds or any of that, and they do present with a viral illness, whether that's just conjunctivitis or other respiratory symptoms, then I do think it's reasonable to test. If you've got that epi link right now, because we're so early in this that there's a fair chance, as I mentioned in the slides, that this is more widely prominent than what we know. We know there are certain infected herds in the 9 states thus far. Again, there's a fair chance, and in particular, if we're seeing very mild disease in humans, that that this is more widespread. And so, if someone tags positive, I know at our facility, if we had asked them the question of they have direct contact, and we found out that they were a dairy farm worker, then I would test them even if they had conjunctivitis. And as I mentioned, actually, a conjunctival swab is appropriate in that scenario.
And then our next question is about signs and symptoms in barn cats, and then are we seeing a high mortality rate there? One of the things I would even say from a dairy or beef perspective, the hard part is, right, you can't really look a cow in the eyes and know that they're sick. What you really see is you see a reduction in like milk production, or you see, oh, they left their feed, from last night. And it's really hard when you have large herds to really discern on a lot of this. They're pretty far down the path of illness by the time they're laying down and not able to get up, etc. So I don't know if that's different with cats or if you've read anything at all, but I would say if they're listless, I mean, they're an elusive animal, right? They hide in barns for a reason. But anything else you would add there?
No, not really. No, I know that they've seen clinical disease in these cats. So it wasn't that they tested them and they were completely asymptomatic and that sort of thing. That may be the case with some of them, but I know that that they have sent, or there is some guidance for veterinarians, just thinking about some of the symptoms that can be present. And so it does sound like that those cats were, at least some of them at least, were symptomatic. And as you said, not definitely not but I imagine listless and things like that. But as you mentioned, barn cats are sort of hard to keep up with anyway, so that may be difficult. But they are testing those animals that are on property of of those farms that are known to be infected. That is part of the investigation process.
Thank you. The next question is about raw milk. So we already know that there is investigations happening with raw milk, and raw milk is not a practice that, I think for most of the dairy associations, et cetera, there's a strong desire that pasteurization has to be done for safe handling. Anything else you would add there, Dr. Hewlett?
I mean, I'll say, as an infectious diseases doctor, I am very biased in this area, only because there are definitely other diseases. I mean, brucella is a really good one that we do see every once in a while, that are linked to consumption of raw dairy products. And whether that's raw milk, raw cheese made with raw milk, raw cheese, there are a variety of different, different things that you can get from that, not just potentially avian influenza, but yeah, I mean, there have been many health warnings from all of the agencies as well as other groups and such about raw dairy products that I think are also relevant to this scenario.
Yeah, great. And then the next one is about any advice for small flock keepers in security and prevention. Again, there's lots of really solid education and training out there for biosecurity for animals. So I would just suggest you connect to your extension agent, or USDA's got some great stuff on their website as well. In dairy right now, really significant biosecurity expectations and really suggested strategies about when to wear PPE and how to do that with infected dairy farms, et cetera. So it's quite significant. And as we remember, the avian influenza in bird flocks has been going on for quite some time. So some of these folks with birds, turkeys, et cetera, are pretty good at this point. All right, the next one, surveillance of beef cattle. I do think that that'll be forthcoming. Currently, not yet. So more to come on that. And again, we probably aren't the best to identify that. A question about, has the virus been identified in eggs? Any comments on that, Dr. Hewlett?
Yeah, I mean, so not as of yet. That being said, obviously eggs could potentially present a risk. And so there is a notation on some of the guidance documents that just says that you should, cook your eggs. So consumption of raw eggs is not recommended. But there have not, at least in the information that I've obtained over the last, few weeks dealing with this, they have not isolated this virus in eggs as of yet.
And then our next question is, given that it's crossed into cattle now, dairy cattle specifically, is it also crossing over into deer populations or other split hoof animals? Have you heard of many cases of deers? I know there's been several mammals.
Yeah, there are a fair number of mammals. There was a goat actually that was infected up in, I believe it was Minnesota. So there definitely been some, some reports in other animals. And as I said in the presentation with that, that pyramid that I showed, lots of different mammals actually can potentially be infected with this. And so that's the reason that during this investigation, they are actually doing surveillance on surrounding animals, wild as well as the ones that are actually on the farm. And the reason is because there's definitely a potential to, for this to spread into, adjacent populations of mammals.
Great. So you, Dr. Hewlett, talked a little bit about the epi risk, assessing sort of respiratory influenza-like illness, conjunctivitis upon entrance into the healthcare system. This is a good practice regardless, as I might go on a soapbox for just a moment, with measles really mitigating spread in your waiting rooms and exposure to your staff, meningitis, all the above. So it's a good idea just to ask those fever, rash, cough questions out there. But I think it will take a little bit of time and probably some additional cases before we have the clear epi questions that would be added to that. But like we've told our ER here and urgent care and others to really work, if you've got somebody with symptoms like this, ask the question, right, about contact with ag animals, production facilities, et cetera. So not yet, but I think it'll be very quickly. And we do have quite a few of our national special pathogen folks on various travel advisory groups, like Dr. Hewlett and I sit on the EPIC one for our emergency, our EMR. So EMS, I mentioned briefly that we will have some information out from netech.org by later this week. And again, if you have not subscribed to our newsletter there or blogs, please go out on our website and do so, because you'll know when new information is added. And that's a really good source for truth as it relates to healthcare mitigation and things that we should be doing. The next question is, how will hospitals know if the patient has H5N1?
Yeah,
so I'll let you.
Yeah, that goes back to, to the testing, question and some of the information. as far as making sure that we're doing the appropriate tests on these individuals that we identify with epidemiologic risk factors. And just again, to clarify, these epi risk factors may change over time. And so it may be that we start to see human cases linked to consumption of whatever foods, whether that's, raw eggs or raw milk or whatever. And so we need to make sure that we're fluid with those epi questions. And I know, Shelley answered the question earlier. She's our travel guru here as far as travel screening and symptom screening up front, which is a really, really important component of our, operations and our clinics and our emergency department, making sure that we're screening those individuals appropriately. And so, yeah, I mean, I think what I can advise is just making sure that we, along with identifying the potential patient that has a risk, making sure that we're running the appropriate test on that. And as I mentioned, that really needs to be a conversation with your local lab to make sure that you are, that whatever testing you're able to provide, there are a variety of different PCR tests for influenza A, as well as antigen tests and such. I mentioned that the antigen tests right now are not going to likely or have a very low sensitivity to detect this current virus, but that may be something that in the future we may have antigen tests for this, similar to what we experienced with COVID. But make sure that you're reaching out to your local lab to find out not only, what specimens do I need to collect, but what is testing going to look like? And that is really variable between facility to facility. I listed some of our testing mechanism here, but that is definitely not across the board necessarily. And so I would just advise to contact your lab leadership and make sure that you have a mechanism in place for testing so that you can identify these cases.
And then, Dr. Hewlett, let's talk for a minute about why N95 for PPE. Are we suggesting that when we don't do that for just general influenza, which is more of a droplet?
Yeah, that is an excellent question. And I will say right now we don't know enough about this illness as far as its transmission dynamics. Is this something different from other influenza viruses? Is there more of an airborne component to this? Influenza in general is not always just a droplet disease. I mean, this is a disease that the majority of transmission does occur, within that kind of shorter, or smaller space where, droplet precautions are appropriate for the vast majority of infections. That being said, someone who has a high viral load, someone who is undergoing a aerosol generating procedure or other things, there's definitely a chance that influenza can be transmitted via the airborne route. And that would require something like an N95 respirator. And so when we have one human case and we don't know a whole bunch as far as the transmission dynamics of this, it's advisable to go with the N95, and that is something though that could change in the future. But for right now, that's what's recommended.
And then, quick question: if you could put on your crystal ball and your hat, any speculation from CDC or the WHO yet on potential pandemic? I know the answer is no, but just anything else we're monitoring or things to just be mindful of.
Yeah, I mean, this is something that, these cases, though, if you think about it, we've had H5N1 cases around the world, since 1997. And they've been sporadic. The difference would be if this virus acquired the ability for sustained transmission human to human. And that is not something that we've seen thus far, but it is a possibility. And so that's where we fall into that or think about that pandemic potential is if this virus evolves into something that does have easier transmission person to person, that's when we were worrying more about a pandemic. And so that's something though that I think, again, we have to continue to watch this really closely and, keep up to date with all the most relevant information just to make sure that we're really following this and tracking it.
And one other question, then I'm going to go to the two folks that have their hand raised. The question is how likely do we think the transmission to dairy farm workers is due to aerosol transmission from respiratory secretions from cattle or aerosols from power washing? And all I can say is it's a very wet environment. It could be any of those. And there's been very limited ability to get into dairy farms to really analyze what is truly happening from a transmission perspective. It could be all the above. I think time will tell, but the goal would be to try to get in there and figure out what is it. We know cow to cow, How do you, I mean, there's just so many potential answers here that could even be all the above. So I'm going to go next, and Roseanne, thank you for being patient. If you want to unmute, I see your hand is raised. And maybe, are we able to let her unmute, you guys? I think we have to allow her to unmute. They're working on it. All right, Roseanne, are you on? All right, maybe we lost Roseanne. Any way you can put that in the chat for us, Roseanne? And I think there was one other person. Anybody with their hand raised able to speak up and ask their question? All right. One other quick question in the chat or in the Q&A here that I'll have you answer was, what sort of respiratory pathogens do we look for when somebody comes in with respiratory symptoms? Do you know what our panel sort of all looks for, Dr. Hewlett?
Yeah, there are many viruses actually on our panel, as well as, and it totally depends again on your local testing, but our respiratory pathogen panel also has some bacterial pathogens as well. And so it is really intended for a, kind of wide look at someone who comes in with a respiratory illness. And we do this in particular with, like, for instance, our immunocompromised patients, transplant patients, where some of these illnesses, the viral illnesses, are not necessarily treated in immunocompetent individuals, but may actually be treated with antiviral medications in immunocompromised patients. And so there are actually there's a wide array of viruses. I mentioned, influenza, as well as the SARS-CoV-2 are definitely on those panels, but also parainfluenza, a wide variety of different adenovirus, other viral illnesses that could potentially present. Now, that is a wide look. That's called a respiratory pathogen panel. There are others that are much more directed, where you would have to individually test. And so that's something, again, advice to, go talk with your lab director and make sure that we've got, you have the testing thing covered.
Great, thank you. And are we able to hear from anybody with their hand raised at this time? And if not, we would love for you to email us your question, and we will get back to you. So I'll pause for a second. All right. So with that, we are at the top of the hour. So at the end of our time, we were able to answer all the questions in the Q&A. Please email the email that Lauren just put in the chat or in the Q&A there if anybody has additional questions we weren't able to get to today, and we will follow up with you specifically. The chat or the webinar slides, as well as the recording, will be posted on our websites here in the next 2 or 3 days. So please reach out in the meantime, and hopefully we've given you lots of resources and ways to connect to us should you want that and need that for any questions at all. So thanks a lot, and have a good rest of the day.